So one challenge is that, we still do not have a curative treatment when we are talking about systemic therapies. And also for monotherapy, with immunotherapy, we still have a lot of patients that do not respond to the treatment. For the responders, the outcome is excellent, as we have seen it in other tumors. But there are still a lot of patients that do not respond to immunotherapy, which means we would either need good biomarkers to identify the patients that are candidates for either treatment. We have now many options available. Or we need to find better combination therapies. And there are some combinations that has been published at ASCO and also today, in which immunotherapy has been used in combination with either antibodies like Avastin, bevacizumab, or with TKI, lenvatinib. The first data were extremely promising, response rate up to 60%, which were really amazing. Today we got an update and the response rate dropped a little bit to 32%, indicating that this is also not the major breakthrough, but when we take everything together, these data which we have seen, there's clearly an indication that the combinations are more active than the monotherapy, and I'm quite convinced that in the near future we will see combination for TKIs, antibodies with immunotherapy as first-line HCC treatment. Unfortunately, we do not yet have any biomarkers. For sorafenib, we really did a lot of, and Bayer did a lot of studies to find biomarkers to identify patients that would have a better benefit from sorafenib. In the lenvatinib study, we have also a very good liquid biopsy analysis, and which kind of indicates that specific cytokines are going up and down depending on which drug you are using. But what we really need is a biomarker which we could use to identify before treatment which drug to which patient we could give. Yeah? And so far, neither for the immunotherapy nor for the TKIs there's any good biomarkers. And in the end, the only biomarker we do have is AFP. So from the REACH2 and REACH1 study, we have learned that ramucirumab is only active in patients with a high AFP level. So a group of patients with a very poor prognosis, and in this group of patients, ramucirumab leads to a significant improvement in overall survival. So AFP, a very old biomarker, tumor marker, but nothing fancy which we could use at the moment in the clinic. Liquid biopsies, if we would have good biomarkers, which we could use also as liquid biopsies, we could either select first which treatment would be best, which would be specifically important in HCC because we can make the diagnosis without histology. Yeah, so just by the CT scans or MRI scans, we can make the diagnosis. So per se, a patient does not really need a biopsy. Yeah? Having a liquid biopsy or a marker which would also could be tested as in the blood would be really helpful for these patients that are not receiving a biopsy. And then, of course, it would also be nice to follow up on treatment, maybe to identify early resistance or also mechanisms of resistance, how we have seen, as we have seen it in other targeted therapies, such as with the FGFR inhibitors for patients with FGFR2 fusions, for example, in cholangiocarcinomas. So I think there are many indications where liquid biomarkers could be extremely helpful. But as I said, so far, unfortunately, we do not really have anything in the HCC field.